Hi, everybody. Thanks so much for joining the Evoke Neuroscience Lunch and Learn webinar today. My name is Morgan Edmonson. I'm the Director of Medical Affairs here at Evoke. And before we get started on our webinar regarding how you can use EVOX for chronic pain patients, I just want to make sure that everybody can hear me loud and clear. So in your GoToWebinar menu, there's a little box that has questions, and it should have a text box where you can type something in, and I want you to tell me wherever you are in the country right now, how's the weather? I am currently in Northern California. It's a beautiful sunny day, but it does still feel like fall. We've got some falling leaves, they're turning red. It's quite beautiful. So just type in that question box, let me know that you can hear me and that you can see my screen, and we will be good to go. Awesome. Other people have good weather too. Good to be in California. All right, great. So as I said, my name's Morgan Edmonson, and I'm typically your host for these Lunch and Learn webinars, but today we have a special guest. Dr. James Thompson is with us today. He is an Evoke co-founder and PhD as well. So he's going to be walking us through some important biomarkers, electrophysiology biomarkers that you can use measured by your EVOX system to kind of recognize signs of neuropathic pain, really focusing on neuropathic pain, specifically within the central nervous system today, as opposed to nociceptive pain. So we'll make that differentiation, and Dr. Thompson will get into that a bit more. So at this point, I'm going to hand it over to Dr. Thompson, and if we have time at the end, feel free to type in questions to that question box. You know where it is. And we can go through some of those questions. If we don't get to all of your questions, I'll be happy to reach out to you after the webinar to get them answered. And at this point, Dr. Thompson, you can take it away.
Okay, thank you, Morgan. Let me just bring up my screen for the presentation. Great. All right, just launching it here. Okay. Morgan, can you just confirm that my screen is up with the title Lunch and Learn?
It doesn't look like it. Let me
check my screen sharing. Not up.
All right, let's try it again.
Try to make me presenter again.
You know what, James? Why don't we, I can click through for you until we can figure out how to make you the presenter, because GoToWebinar is being a little bit funny right now. So I'm happy to advance through slides for you.
Okay.
As long as you can still see my screen.
I believe I can lunch for chronic pain.
Oh, there we go. I think I got you now as the presenter.
Good. Thank you.
By sharing your screen. Perfect. Okay.
Okay. All right, Morgan, let me know if anything doesn't progress as it should.
All right. You look good to go.
Thank you. Okay, welcome to the Lunch and Learn. Thank you, everyone who has joined. What we'll go through today are slides and biomarkers on chronic pain. We'll do a little bit of background on some of the measures, but a lot of the information, basics on EEG and heart rate variability, can be found in our other Lunch and Learn seminars. You can contact Medical Affairs at Evoke Neuroscience for that, and I'll provide the website at the end. So our objective today is to strengthen your understanding of using electrophysiology in chronic pain patients. We will look at differentiating the medial and lateral pain pathways. We will look at 3 key biomarkers of electrophysiology, and we'll look at a few case studies so you can see what this looks like in the Evoke reports. A little bit of background on chronic pain. As most of you know, we're only scratching the surface when we get self-reports of pain. There are many symptoms associated with chronic pain, and we really need to understand not just what those symptoms are, but what the underlying causes of the symptoms are, so we can guide our treatment towards those underlying root causes, and we can track the treatment progress by following the biomarkers changes. It is a huge problem, probably why we have so many attendees here today. 116 million Americans are suffering from chronic pain, and it's the #1 reason that they access the healthcare system. $635 billion is spent on treating chronic pain. There are multiple symptoms, as we saw on the last slide, including sleep issues and mood disorders. There is a 70% greater risk of mortality from chronic pain, even exceeding that of cardiovascular deaths. And 98 million prescriptions were provided in 2012 for chronic pain. But what we'll focus on today is neuropathic pain. And these NSAID medications are generally ineffective for the neuropathic pain type, which is the pain that affects the central and autonomic nervous systems. So why do we have this current problem? Well, the current tools are focused on self-report and rating systems, and they're subjective, and they have relatively poor accuracy, and they don't provide us any information on the underlying mechanisms causing the pain. If we start to look at the neurologic side of it, we can measure the changes in the brain that occur due to neuroplasticity in chronic pain patients, and then we can treat the underlying root causes of the pain. If we treat the peripheral side, we also have to treat the neural side, which has become negatively affected in these pain patients. It almost becomes hardwired that there is a feeling and an emotional aspect to the pain. If we look at the cycle, there is a cycle of stress and pain, where blood flow in chronic pain patients shifts from the frontal lobes and the conscious thinking more towards the limbic system, which involves the emotional side of pain processing and the fight or flight response. So the amygdala is activated, and it then therefore activates the autonomic nervous system, sending a whole host of changes to our body, including the GI system, cardiac responses, and even muscle spasms. The anterior cingulate provides emotional responses to this chronic pain, and it is overactivated. And we therefore also reduce the dorsolateral prefrontal cortex activity, which actually would have helped these patients modulate and reduce the perception of pain. So if we're going to treat chronic pain, we need to measure the brain and ultimately treat this plastic response that has occurred that has changed the brainwave patterns in chronic pain patients. So chronic pain patients actually process pain differently, which we'll see as we move through the webinar. And these biomarkers can be measured and also tracked as we apply therapies. So chronic pain, as many of you will know, does have an effect on the brain. It actually reduces gray matter volume, leading to many of the symptoms that we associate with some of these chronic pain patients, such as cognitive abilities, memory impairments, and emotional problems. So the key biomarkers we'll focus on today include the electrocardiogram and its measurement through heart rate variability, the electroencephalogram in 3 aspects. There's a peak alpha frequency, which we will cover. There is the brain power, ultimately the amplitude and power generated by the neurons, and the localization of specific components of the brain and pain network. So heart rate variability, again, a high-level overview. The information contained here is available in other slides covering the specifics of heart rate variability. Essentially, what we have here is the sympathetic branch and the parasympathetic branch. Ideally, they are maintained in homeostasis, and there is a balance between the two as the body shifts dynamically from sympathetic to parasympathetic throughout the day and appropriately to certain circumstances. We measure this through the beat-to-beat intervals, which vary throughout the day and in response to different stressors. We want a high amount of variability, which means we are adapting in a moment-to-moment basis. It is highly variable. You can see here the R peaks in the electrocardiogram. They vary beat to beat, so constantly, and that is a nice amount of variability. Indicates good overall health, autonomic resilience, and lower stress levels. Okay, we'll jump over this, but what we essentially do is we take these beat-to-beat changes and we measure them in a frequency domain. So we have very low frequencies, we have low frequencies, and we have higher frequencies. That's how we break them down into the three categories. And you can see here on the bottom right, the very low frequency. On the left, the lower frequency, and the high frequency is how we represent this graphically. You'll see this in our case examples. Okay, in chronic pain, we actually end up seeing a reduced amount of total variability. There ends up being a sympathetic dominance, so an excess in that very low frequency on the left-hand side of the graph. And you can see this here from one of our reports, where the very left-hand side, representing the sympathetic overactivation, is much higher than the other two bars. In a balanced system, the low frequency would be dominant, not the sympathetic very low frequency. We look at SDNN as a measure of this amount of variability. We look at total power, demonstrating the amount of vagal tone, the activity of the vagus nerve. And we look at the distribution in the frequency spectrum, and we see a stressed nervous system here indicated by sympathetic overarousal. Here's a research study in chronic pain patients, veterans actually, and you can see on the left an indication of changes in heart rate variability, the measure here being heart rate variability coherence. In the pretest, there was no difference between the control and the treatment group, but you can see after training of heart rate variability and changes in the heart rate variability measure, the coherence, the heart rate variability measure goes up in the treatment patients significantly. And on the right-hand side, you can see how that led to reductions in reported pain levels and significant reductions in negative emotions. So you can see how targeting one of the biomarkers, changing the level of heart rate variability, changed the biomarker, which we would track during our treatment plan, and significantly reduces the pain levels and associated symptoms such as negative emotions. The next biomarker is the peak alpha frequency. It is an overall measure of cognitive ability. It's generated in the thalamus, which we will cover later, significantly is negatively affected in chronic pain. And it's generally measured in the alpha band, which is 8 to 12 cycles per second. It's a rhythm in the brain. Here you can see a frequency distribution, 0 on the left, so no frequency, up to the faster frequencies in the beta band, up towards 30 hertz. And you can see the dominant peak right in the middle at around 10 hertz in that alpha band. That is the peak alpha frequency. So it has a range, generally between 9 and 11 hertz, or cycles per second. There is a slight decline with age, which has a known trajectory. We also know that more intelligence or more highly intelligent and good performers on memory tasks have a higher resting peak frequency. So there is a slight inter-individual difference, which you should take into consideration when looking at your patients. However, in chronic pain patients, there is a slowing of this peak frequency. And this can be tracked with changes in the status of the chronic pain patient. Research has demonstrated an 87% sensitivity when you look at peak frequency of the alpha band combined with EEG power, which we will cover in the upcoming slides. Here you can see the red are fibromyalgia patients with a peak frequency that is lower, or slower, I should say, slower, more towards the 5, than the healthy controls, which is the blue line, which is more towards the peak of 10, so it's faster. You can see in the graphic on the right that the peak frequency for the fibromyalgia patients in this research is in red, and it is significantly lower than the average peak frequency for healthy controls. So decreased peak alpha frequency is a demonstrated biomarker of chronic pain. So what do we look for? We look for a slowing of the peak alpha frequency, maybe moving from around 10 cycles per second more towards a 9 cycles per second or lower. But do consider the baseline, because more intelligent people might not have as significant a shift. Here's an image again, the orange being the chronic pain patient, and they have a slower or more towards the left peak than the green being the healthy controls. And there's that being indicated by the red arrow, chronic pain. There is also excess power in the EEG of chronic pain patients, which we'll cover in the subsequent slides. Here you can see the patients, the chronic pain. Again, that peak is slower or more to the left than the controls, which is blue. You can also see it significantly higher up on the graph on the y-axis, indicating that there's more power in that frequency band. Here you can also see the chronic pain patients are shifted, their peak alpha frequency is shifted more towards the left than the green healthy controls, which are further right on the x-axis. And as we move into talking about the amount of power, you'll see that those orange chronic pain patients are higher up on the y-axis than the less power of the healthy controls. So let's talk about this power in the EEG. It is the amplitude or the voltage in the brain. We look at this voltage across a frequency spectrum, all the way from the slowest frequencies towards the 1 or 2 cycles per second, all the way up to the faster frequencies. The delta are the slowest frequencies. Theta indicate moderate to slow frequencies associated with drowsiness and poorer cognition. Alpha is a resting state, that background rhythm. We talked about the peak alpha frequency. And beta are the faster brain waves used for cognition, thinking, and learning. The amount of each frequency is the amount of power that we measure in each band, or the amplitude. So we look at, in head maps, we look at the slowest frequencies all the way through the fastest frequencies, and we measure how much power there is in each one. Is it appropriate for the state that the person is in? When we compare this to a database, this is where we look at the amount of power. Low power is generally indicated in blue, as you can see on the left-hand side of this graphic. Too much power is indicated by red in any given frequency band. Again, all of this information is covered in our other lunch and learns on the electroencephalogram. But what we generally look at here and the questions we ask are, what frequency? Is it slow or fast? What power? Is there too much or too little? And where is that? Is it in the frontal regions, the temporal regions, parietal regions, etc.? That has to do with the function of the brain. Now, what do we see in the chronic pain patients? We typically see higher power, so more red in more of the frequencies. It tends to be a global phenomenon. So the brain is running excessively in producing more frequency, more power in each frequency band. Look at things like inflammation, you look at cortical dysregulation, and you look at a lack of inhibition in the central nervous system. When we look at the quantitative or digital analysis of the electroencephalogram, we can look at the amount of power in each frequency, and we look at this increased power as a result of thalamocortical dysrhythmia, or TCD, which is a known phenomenon in chronic pain. There is a dysregulation of the thalamus and its gating of frequencies being generated and communicated through the cortex. It is a hallmark of the underlying neurogenic pain, this thalamocortical dysregulation. And we see this mainly in the regions of the cortex associated with interpreting pain in the cortex. So, in summary, a global excess power is a demonstrated biomarker of chronic pain. How does this look in our head maps? We'll often show excess power in the frontal and parietal regions of the brain, and it will often appear globally in multiple frequency bands, the slower theta bands, the alpha bands, and the beta bands, which have a lack of inhibition. If we look at changes in these biomarkers after a therapeutic intervention, such as a CLT, you can see here that following surgery, there is a significant decrease in the amount of theta power, and there is an increase in the speed of the peak alpha frequency. So you can see orange is immediately before surgery. Following surgery, there's a slight reduction in the theta power, but 3 months later and 12 months later, in particular, you see a significant reduction in power. That's the peak's going down. And you see that the peak alpha frequency is faster. The peak has moved more to the right-hand side of the graph. This is indicating changes in the theta power following surgery. And you can see that all subjects demonstrated a reduction in theta power. That is a normalization in the biomarker, less theta power. So that is a key marker for indicating changes in the biomarker, which is this global increase in EEG power. Talking a little bit about the pain matrix here in the brain. There are two pathways. There's the medial pain system and the lateral pain system or pathways. The medial deals with the emotional responses, and these inputs go more towards the limbic system. And the lateral is more towards the sensory system. So if we look at a little bit of detail here, the medial pain pathway is responsible for the emotional aspects of pain. How is it interpreted? How unpleasant is the pain? This has multiple areas associated with it: the anterior insula, the anterior cingulate, the prefrontal cortex are all part of this medial pain pathway. The lateral pain pathway, on the other hand, is more about the location and intensity of pain. This involves the somatosensory cortex and the posterior regions. If we want to focus on these, we need to use a technique of source localization, which we can now perform using the electroencephalogram. This allows us to measure the areas responsible for the medial pathway, so how we interpret this pain on the emotional side, including the anterior cingulate activity and activity in the insula. And we can also do source localization for the lateral pathways. Where is the pain and how intense is that? And how are these regions of the brain responding? If we look at these regions, we know that chronic pain through research demonstrates abnormal frontal and parietal network connections. So the frontal lobes and the parietal lobes that deal with the emotional and sensory components of pain, they are linked or coupled in an abnormal way. There's actually, in the default mode network of the brain, there is an inability of chronic pain patients to deactivate this default mode network. So the medial prefrontal cortex, the amygdala, and the posterior cingulate, have a dysregulation compared to normal controls. There is enhanced EEG, or enhanced power, in the areas related to the cognitive and emotional modulation of pain. So there is a consistent perception of the pain and an enhanced reactivity to the pain inputs. In a quick summary of these brain biomarkers, you can see that the chronic pain has higher or more dysregulation in its chemical inputs into thalamocortical regulation. There's a decrease in the gray matter volume in the dorsolateral prefrontal cortex. There are altered connectivity in the posterior and frontal regions. And there are changes in the nerve tracts and the way that signals are communicated throughout the brain. This causes changes in the sensory aspects of pain, the affect and emotional responses to pain, the cognition and cognitive abilities of chronic pain patients, and the emotional states of chronic pain patients. All right, so we look at these 4 biomarkers in summary. There's the autonomic nervous system, which we can focus on, and we see a stress in that, or a sympathetic overarousal. The peak frequency is generally reduced in chronic pain patients, so it is slower. There is an excess amount of power, so higher EEG, and there is changes in the source localization of the pain patients. Sorry, 1 second here.
As Dr. Thompson is attending to what he's got going on in the background there, if you guys have any questions that have popped up, feel free to type those into your GoToWebinar menu. It looks like we will have some time at the end here to answer a few of those questions. So as they come up, feel free to type them in, and we will try and get them all addressed when we wrap up here at the end.
Okay, sorry about that. Back online. So let's look at some of these case studies. What are we going to see in the chronic pain patients and in the Evoke report? Well, here's a 70-year-old chronic pain patient. You can see on the left, we have reduced SDNN and reduced total power, the measures of vagus tone and inputs to the nervous system and changes in the autonomic activity. You also see this increase in sympathetic activity on the left-hand side. That demonstrates sympathetic overactivation. On the right, along the top, you can see the area denoting the peak alpha frequency. And recall that normal peak alpha frequencies are between about 9.5 and 10.5. And here you can see this is significantly lower at 8.4, highlighted in yellow. And recall that in multiple frequencies, including the theta, the alpha, and the beta bands, we often see higher power throughout the brain. That's indicated in red, or an excess compared to the database. So here's a classic profile of chronic pain patient who would also have additional symptoms, as we discussed earlier, including emotional and cognitive dysregulation. Here is a slightly different profile, but includes the same markers of a stressed nervous system. On the left, we can see here that there is an excess in the parasympathetic activity, as well as an increase in the sympathetic activity, with this balanced centered one, the low frequency, being the lowest. That is a classic stress profile indicated in the autonomic nervous system. The peak frequency is at 9.0, so it is at the lower, much lower end of what you would expect, especially in a 55-year-old. And you can see, again, throughout all the frequency bands, we have an increase, or red, in particularly here in the frontal lobes. And we noted that there is dysregulation in the prefrontal cortex and the dorsolateral prefrontal cortex as well. Here again, if we look on the left-hand side, we see an SDNN of 60. We see the sympathetic overarousal indicated by this high red bar in the sympathetic or very low frequency. We see a peak alpha frequency of 7.2, so very slow. And you can see, again, this red throughout the brain and throughout multiple frequencies, indicating an excess power in the electroencephalogram throughout multiple frequencies. In contrast, this is a 60-year-old dementia case, and you can see a significant difference. Although they do have poor cardiac system, often seen in older and dementia cases, you see that the red is isolated to the slower frequencies, 2 to 7 hertz. It is not found in the higher frequency bands, in the beta. So if you have a quick look as we flip through again, notice that in a dementia case, the excess power, or red, is isolated to the slower frequencies, indicating brain slowing. Whereas in chronic pain patients, the excess power is more distributed throughout multiple frequency bands. So that gives you a visual difference between these chronic pain patients with red in almost all frequency bands compared to a Alzheimer's case where the red is isolated to the slow frequency bands. You end up with blue in the faster bands. So this will conclude our webinar. There is a fair amount of information, but what we can take away is that there are significant biomarkers in the nervous system, the central and autonomic nervous system, that can help guide our diagnosis of chronic pain, indicate changes that have occurred in the brain due to neuroplasticity and changes in the way the brain is wired. And as we provide therapies for chronic pain patients, we can track these biomarkers to guide our therapeutic interventions and demonstrate treatment success in changing the biomarkers, which ultimately results in a change in the condition of the patient and the symptom patterns.
Great. Thank you so much, Dr. Thompson, for that review. I think we all learned a lot about chronic pain. It does look like we have a few minutes here at the end to answer some questions, and we've actually got a lot submitted today. I've been able to answer some via text, so if you answered a question, check your inbox. It might already be in there. But Dr. Thompson, we have some questions for you, and the first is going to be how peak alpha frequency might be correlated to excess power. Dr. Hartman has asked this question, and we did review peak alpha frequency and excess power as two biomarkers today as they relate to chronic pain. So are those two always correlated, or can they sometimes differ?
Right. So peak alpha frequency and excess power can differ. So I'd like to go back to a slide if I can bring it up. Let me just find the slide. So the peak alpha frequency is referring to the speed or the background rhythm, the background speed of the brain. And think of that as your speedometer. How fast is the car going? Can you see my, let's see here. Look for. Are you seeing the full slide of the peak alpha frequency with the graphics on it?
We're seeing your presenter view, but yes, we can see the slide.
All right, let me go to slideshow.
There we go.
Okay, so if you think of the peak alpha frequency as the speed, the speedometer, it's how fast your brain is going. And you want that to be going a certain speed. The RPMs is more like the power. How much power are you producing to get that speed? And they can be correlated, but they can be independent as well. You can be going slowly and have a high RPMs, or you can be going quickly and have low RPMs. So they can be independent. You can see people with chronic pain who will generally show excess power. So you can see how high this orange line is in the middle graphic here. But they don't necessarily have a slowing in the peak frequency. It may be because they're highly intelligent. It may be that they started with a very fast peak frequency, and it may be that that frequency was not affected by the slowing. But they will more often than not demonstrate the excess power because there's dysregulation of the thalamus and the gating of the inputs to the brain.
That's great. I feel like that's a really great analogy to use for patients as well, kind of describing the difference between power versus our peak alpha frequency. Dr. Thompson, we also have a question from Dr. McGettigan, kind of concerning what effects we might see with medications and if we could expect to see an improvement in biomarkers if a patient is on a medication that's working for them. And also kind of a tag on to that is what might we see as a result of opioid medications on these biomarkers?
Okay, so medications obviously can have an effect on the brain. We did touch upon earlier that it has to be an appropriate medication to have an appropriate response. So if you use, let's say, an NSAID or an anti-inflammatory medication, it's not going to have the desired effects on the central nervous system. It will help with the peripheral issues. But a norepinephrine reuptake inhibitor, such as an antidepressant, in low doses has actually been shown to have very positive effects on the central nervous system. So if the appropriate medication is used, then the appropriate response in the electrophysiology will be demonstrated in the patients. So that covers the medication side. And then we look at the opioid side, and you'll see that opioids generally have the effect of slowing the electroencephalogram. And that can affect the cognition of these individuals, their I guess, perceived sharpness, let's say. And that will be reflected in a slowing of the electroencephalogram and a move towards slower frequency dominance.
Great, that makes a lot of sense. And I think it also relates to sometimes patients on these heavy pain medications feeling like they're in brain fog. And sometimes we do see patients that are so heavily medicated with memory loss symptoms. And sometimes it takes putting them on a different medication or sort of weighing the cost benefit of having them so heavily medicated when cognition can start to really slow down because of that kind of brain activity suppression, which the meds are doing what they're supposed to do, but we need to kind of balance that out to make sure that cognition isn't being severely impaired because of it.
Exactly, Morgan. And that's why alternate therapies or adjunct therapies such as exercise, cognitive behavioral, physiotherapy, even the use of antidepressants can be very helpful. But you have to watch out for any contraindications or multiple medications.
Absolutely. Great. Well, I think that's all the questions we have time for today. Thank you so much, Dr. Thompson, for joining us. We really appreciate it. There are a handful of other questions we didn't get to, so I'll be happy to respond to those questions via email. Certainly reach out if you have follow-up questions that you want to discuss. I'm available at medicalaffairs@evokeneuroscience.com. We also will have this recording available to you all via a link to this recorded webinar. So don't worry, you can revisit it if you want to, share it with your colleagues if they're interested as well. So we're happy to send you that link later today, and I'll be here for any future questions. Thank you all very much for joining us, and please enjoy the rest of your day.
Thank you.